I'm Roland Griffiths. I'm professor in the departments of psychiatry and neuroscience at Johns Hopkins. I'm a psychopharmacologist, that is, I study the interaction of behaviorally active drugs and behavior. And I've been doing research preclinically and clinically for 40 years now at Hopkins. About 12 years ago, we initiated our studies, human studies with psilocybin, and that's been a really fascinating adventure to unfold. We actually initiated our studies in about 2000. The first couple of studies focused exclusively on volunteers, healthy volunteers, with no pathological conditions. And the principal finding from those studies was that psilocybin, when administered under supported conditions to healthy volunteers who were well prepared for these sessions, occasioned experiences that really map on to the naturally occurring mystical type experience reported by religious figures across the ages. That mystical experience, although it sounds a little loosey-goosey, actually has been well defined by psychologists in the psychology of religion. And it is comprised of several features: a sense of the interconnectedness of all things, that's a unity; a sense of sacredness; a sense that the experience is more real and more true than everyday waking consciousness; a sense of open-heartedness, love, positive mood; transcendence of time and space; and finally, ineffability. People say, I can't possibly put this experience into words. And so we were able to show quite rigorously that psilocybin, high doses of psilocybin, can occasion experiences of this sort. When we give the psilocybin, it's to these well-prepared volunteers in an aesthetic living room-like environment in which they're laying on a couch. They have eye shades and headphones through which they listen to a program of music. We ask them to direct their attention inwards, and from that, the phenomenology of these experiences come out, and most people, it's about 60 to 70%, have these so-called complete mystical experiences. Now, what's interesting about these experiences is that not only are they very salient and compelling at the time that they occur, but on follow-up, people attribute remarkable salience continue to attribute remarkable salience to the experience, and in fact, rate them as among the most personally meaningful and spiritually significant experiences of their lives. So that's really quite a remarkable metric, and we've pushed people on what that means, and they might compare the meaningfulness of this experience to, say, a birth of a firstborn child or a death of a parent. But these are big experiences. Not only do they have that level of salience, people are reporting long-term changes, positive changes in attitudes, moods, and behaviors due to these experiences. So there's a sense of increased self-awareness, increased sense of personal integration. People feel less depressed or more buoyant moods. A lot of pro-social kinds of attitudinal changes. People feel more of service to others. They feel more loving, compassionate, attentive, and sensitive. One of the questions that we asked immediately was, are these people delusional? Are they just making this up? Would other people, in fact, endorse these kinds of changes that they're saying? And it turns out that they do. So we've done follow-up studies with community volunteers, in this case, family members, friends, or colleagues at work, who, when interviewed in a blind fashion with a telephone, will report changes that map on to what the volunteer reports. So this is a really interesting phenomena. We think it looks like we're tapping into a basic biology of the human condition that in which these salient experiences of interconnectedness emerge. And if you really sit back and reflect on it in the kind of the history of humankind, those are the kinds of experiences that really form the bedrock foundation of most of the world's religions and the world's ethical and moral traditions. So we think we have a biological model for tapping into these kinds of transformative experiences. And now, as a scientist, we can do prospective studies. In other words, we can do planned studies in which we can occasion these kinds of experiences and then study all kinds of things. We can study reductionistically the neuroscience underpinnings of where in brain, what receptor systems, what neurotransmitter systems, what neural circuits are activated during experiences like this. We can study things like in biological psychiatry about how personality factors interact with these kinds of experiences, or how genetics interact with these kinds of experiences, or whether intention or expectation interacts with these experiences. And finally, then there are therapeutic applications that can be focused upon. And we have a couple of trials running with targeting therapeutic applications. One of those is looking at psychologically distressed cancer patients who have either a terminal or a potentially life-threatening cancer diagnosis. They're dealing with the existential anxiety of that diagnosis and the implications. And then the thought is that these kinds of mystical type experiences or experiences of profound insight may have important therapeutic effects to people that are suffering with that kind of condition. And indeed, although the study is blinded, our preliminary results anecdotally would say that the experiences we're seeing map on to what we've seen with the healthy volunteers. And the fact that we're getting a positive signal fits very nicely with older work done in the 50s and 60s, looking at mostly LSD in cancer patients. And then there was a recent study by Charlie Grove out of UCLA. It was just a pilot study using a lower dose that was pointing in the same direction. So we think that's a very interesting prospect in terms of developing medical applications for these kinds of experiences. We have a second kind of therapeutic program running right now. It's a pilot study investigating whether psilocybin can facilitate cognitive behavior therapy for cigarette smoking cessation. So this is addiction treatment. And so that's interesting. It builds on, again, studies done in the 50s and 60s that looked at, again, mostly LSD and mostly treatment for alcoholism. But the question here is, can these insightful experiences, mystical type experiences, be leveraged and used to occasion radical behavioral change? And so far, so good. We've run 5 volunteers. Most of our volunteers in the smoking pilot study remain completely abstinent. We don't have a control group yet, but it's a very interesting application. And the final application, therapeutic application that we hope to start up in the near future is looking at psilocybin as a treatment for depressed patients who have been resistant to other forms of antidepressant medication. And here, this is not really using psilocybin as an antidepressant per se, but the question is, would a reorganizational experience of this sort alter fundamentally the nature of the depressive episode and the nature of the depressive process? It's speculative, but potentially very interesting work, and it coincides with some recent work with a different kind of psychedelic, mechanistically very different, drug called ketamine, that has been shown to have efficacy in treatment-resistant depressed patients. So we're now wondering whether that might be the case, and we hope to initiate studies of that sort. In our work, people are encouraged really to have their own experience. They come into our session room, they put on eye shades, headphones, and we're not guiding these experiences in any classical psychotherapeutic way. We're working with high doses of psilocybin. Now there are, in the history of working with substances like this, there have been a group of studies that have been done at lower doses with psychedelics in a context in which people are working with people therapeutically. That's not our model, but I should also say that our experiences are happening under a context and in a setting condition with intentionality that really may fundamentally organize the nature of the experience and its effects. So for instance, in the pilot study for cigarette smoking cessation, people have these experiences, but it's contextualized under conditions in which they have made a commitment to quit smoking on that day. They have prepared their lives and followed a behavioral cognitive program right up to that point. And actually, at the end of the session, we go through a ritual snuffing out of the last cigarette. So it's contextualized, but these experiences at high doses of psilocybin frankly can be so otherworldly, they can be so distorting that we wouldn't want to presume to interact with people at a conventional cognitive level during the peak of the experiences. Likewise, with the cancer patients, these people are there because they're anxious because of their cancer. They have all kinds of existential questions, but although they may bring into the session an intention to get clarity about what's happening, we really invite them to give up any specific aspiration for the session other than to go in with radical curiosity and explore themselves and explore the nature of the experience that emerges from that. And we actually believe that people are best served by going in without an agenda to this kind of experience and being open to exploring whatever should come up. So in terms of my own involvement with this research, about 17 years ago now, I initiated a regular meditation practice. And that really affected me very profoundly. It got me interested in the nature of spiritual transformation, the nature of spiritual experience. It got me reading comparative religious textbooks and diving into a literature that I actually had no business diving into as a psychopharmacologist. I do drug abuse pharmacology. And there was a curious period of time actually where I was really wondering, how was I to engage in psychopharmacology? Here I am, a drug abuse pharmacologist with an interest in core transformative experiences, until, of course, I became reacquainted with this older literature suggesting that these compounds might occasion experiences that looked like mystical type experiences. I have to say that I went in as a skeptic with respect to that. I had a meditation practice that was deeply fulfilling to me, and I wasn't at all sure that a pharmacological intervention would be useful in terms of addressing some of those same kinds of issues. But I had a grant to study comparative pharmacology of various sedative hypnotics, and in this case including a drug called ketamine, which is a different type of hallucinogen. And what we thought we would do is substitute psilocybin in that study. We initiated it in healthy volunteers. We constructed the study such that if it didn't show anything interesting about spirituality or mystical experience, I could still go ahead and publish it as an interesting comparative pharmacology study. But I have to say, when we initiated that study, and this was when we initially thought about it, it was the late 1990s. It was probably 1997 when I first started thinking about this. The probability of getting approval for that we judged to be very slim. My colleagues, frankly, a number of them discouraged me from doing it. They thought this was a little crazy on my part. These compounds, of course, had been so marginalized and demonized due to what happened in the 1960s that virtually no human research, and to my knowledge, no human research in healthy volunteers without prior exposure to these drugs had been done for over 30 years. And that approval process is a tedious one. We have to go through the Food and Drug Administration, the Drug Enforcement Administration, much less we need to go through our own institution, in this case Johns Hopkins, which is a first-rate institution, but there are also plenty of smart people that are skeptical about whether this was a safe and prudent thing to do. Well, the good news is that we persevered on that and eventually got all those approvals. I'm really proud of Johns Hopkins as an institution for rising to the occasion, putting aside what potentially could have been viewed as institutional liability or institutional risk. They don't want to raise the image of Timothy Leary at Johns Hopkins, but they put that aside, weighing what they believed and we presented as the risk-benefit ratio. And of course, the decision turned out to be the correct one. We now have run over 150 different volunteers, over 350 sessions at Hopkins. We've never had a really clinically significant adverse event. So it's really quite safe under conditions when people are very carefully selected, carefully prepared, and carefully monitored during the session. That's not to say these compounds are safe to use under unsupervised conditions or recreationally. I think there are a number of risks attached to them. So I got into this partly because my interest in meditation, and because of that interest, we have pursued that line into meditation. We've just finished enrolling the 75th volunteer, the last volunteer, in what I think is going to be a very interesting study of the interaction of psilocybin with people who are just making a beginning commitment to a meditation practice. So these are people who have never meditated before. Most of them have never had psilocybin before. And our thought is that there's potentially a convergence, an interaction between these two experiences. Both meditation and psilocybin are very different approaches to investigating the nature of mind, if you will, watching how the mind works, learning from that. And very often, as you go deeply into those kinds of experiences, there emerge phenomenology that looks on the realm of spiritual or religious life. So we're pursuing that, and we also have hope to initiate in the very near future a second and related study investigating the effects of psilocybin in long-term meditators. These are people who we hope will have decades of experience meditating. They'll be very good at introspecting on their inner states. And we're going to look at how psilocybin, how they interpret the psilocybin within the context of their meditation practice. We're going to look at how psilocybin affects their meditation practice. And maybe most excitingly, we're going to actually give them psilocybin during times that they're in an fMRI magnet. So we're going to be able to do neuroimaging studies and look at the effects of psilocybin on very selective tasks and look at it on circuit connectivity within the brain in these long-term meditators. We picked psilocybin to study because it is one of the classic serotonergically mediated hallucinogens that were thought to produce these kinds of effects. So, psilocybin, ayahuasca, which is made from DMT, and mescaline are all naturally occurring serotonergic compounds. Their pharmacology is all mediated through serotonin 2A receptors. LSD is a man-made classic hallucinogen, but it's also mediated through that same receptor population. So the thought actually is that, although these studies haven't been done, that we could have picked any of those 4 compounds and looked at these kinds of effects. Why did we pick psilocybin? Well, one is psilocybin doesn't have the baggage that LSD does. There's so much demonization that occurred, and there's so much cultural baggage and misinformation about LSD and its toxicity that we thought it was good to avoid. Another reason to avoid LSD is the duration of action is significantly longer than psilocybin, and we need to manage these people clinically. And psilocybin has a duration of action that generally is 5 hours, 4 to 6 hours, someplace in there. And so that's much more manageable than a 12-hour session. Mescaline also has a very long duration of action. And DMT, if you administer it alone, is a very short-acting compound, and it's actually not been used sacramentally in the short form. If you use it in the form in which it's administered in ayahuasca, when it's an admixture with a beta-carboline, which slows down its metabolism, increases its duration of action, that's just in terms of the basic pharmacology, then you're administering 2 compounds at a kind of arbitrary dose ratio, and that turns out would be a much more difficult approval path to get that approved. So psilocybin was a great choice, and as one of my colleagues said, and in addition, it's hard to spell. So Rick Strassman did some very interesting and important work in the earlier 1990s with DMT. So that's dimethyltryptamine, that's the active ingredient in ayahuasca. And he gave that drug intravenously. He administered it to people who already had experience with DMT, and he worked out some of the pharmacology of that. It was interesting work. It was with a classic hallucinogen, but it was in users who were bringing in a boatload of expectancies about how that would work. He subsequently stopped that work. When we initiated our work with psilocybin, we were doing so in healthy volunteers who were drug naive. And that was methodologically a very important thing to do, because what we could ask of those volunteers is, from a drug naive standpoint, what kind of effects are produced by psilocybin. We ran our initial study with a positive control compound, a high dose of Ritalin, methylphenidate, but we also did so under conditions where people were blinded to the types of drugs that could be administered. They knew that they would get psilocybin at some time during the experience, but they also thought they could get 14 other different compounds. And furthermore, the monitors, the people who were sitting with them through these sessions, had the same instruction and knowledge set. So everyone, except for just a few of us, were blinded to the drug conditions. And what that really meant is we were pulling apart a lot of these expectancies. And so it wasn't just the expectation of the monitor, wasn't just the expectation of the volunteer. The other problem, if we had used experienced volunteers, we would have biased our sample toward people who had positive experiences, because it'd be unlikely that someone who had a horrendously negative experience would volunteer for a study like that. And so then, therefore, we could get a true picture of what base rates are for negative or difficult kinds of experiences. But Rick Straussman's work was very important, and we in fact have submitted a couple of grants, unfunded as yet, to pursue similar work, because I think DMT is a very interesting compound, and we would like to systematically compare it to some other short-acting hallucinogens. We recently conducted the rigorous trials with Salvia divinorum, which is a hallucinogen with a totally different mechanism of action, and we would love to be able to compare systematically Salvia divinorum with DMT, both very short-acting hallucinogens. There are many interesting questions that could be asked about not only differential pharmacology, but how expectation and orientation interact with the nature of the emergent experience. So in terms of biological psychiatry, and now we're talking about what are the underpinnings of what creates different psychiatric phenomenology, if you will. And there are a bunch of questions that can be asked of that. So some are genetic questions, and there have been very interesting studies that have been conducted that show that aspects of the serotonin transporter system that is marked genetically, and you can take a blood sample and find out whether someone has what's called a polymorphism for certain receptors. That is, whether they have some kind of inherent biological sensitivity for some receptors over other receptors. And some of that work has shown that these genetic differences can account for differences in lifetime experience of the phenomena of transcendence. This has nothing to do with drugs. It's just that some polymorphisms, some genetic components, make people apparently more disposed to have experiences of the ineffable, if you will. And so it would be very interesting to know whether those kinds of biological determinants altered fundamentally the experience with psilocybin or these other classic hallucinogens. As well, there are setting conditions that can be studied to explore the nature of how much of these experiences are controlled by pharmacology versus personality versus expectations. So one study we would love to do is to compare people with vastly different spiritual orientations. Many of our studies to date have been done in a group of people who would consider themselves to be spiritually interested or spiritually awake, insofar as they're curious about matters of spirituality. They might participate in meditation or prayer practice, or at least read about those kinds of things. And those people would contrast, of course, with declared atheists, who subscribe to a total material world frame and don't have any room in their cognitive thought system, for some of these other, kinds of thoughts or way of thinking. And so it'd be very interesting to study and compare those two groups to see what happens under those conditions, and how people interpret those experiences, and whether you can change someone who has an agnostic or atheist orientation to something that looks more spiritual or not. It could be that you don't, but yet it could be that those experiences still have all the embedded personal meaning and salience. It may very well boil down to a difference in language. This word spiritual is really loose. And if you read Einstein, or if you listen carefully to Dawkins, who's an avowed atheist, he'll talk about the mystery and the majesty of the universe and the mystery and the majesty of the biological process that's creating evolution. And if you listen to him, that it would be easy for someone else who isn't a self-identified atheist, much less an icon of that, to say, yeah, I believe that too, and I think that's spiritual. Because we're talking about the mystery, right, of human existence, the core question about what we're doing here, what all this means. How do we explain the fact that we find ourselves awake in this sea of consciousness, in these bodies that can interact in the world, and that at least strikes me as being pretty phenomenal and pretty mysterious, whether you want to call it spiritual or not. So at one level, it sounds like we know a lot, and there are very interesting models about, furthermore, how perceptual processes may be altered through gating mechanisms from reticular activating system up to cortex. And so we have model systems that are beginning to explain what's going on. But I would have to submit that right now, as neuroscience, that we need to be really humble about claiming we really know much of anything. I mean, we don't have a solid hypothesis for why we're conscious, and so these are just very, very crude approximations to providing neuroscience explanations for what's going on. One thing I should say, just that I haven't said, is that everything is not love and light with these psilocybin experiences. And although we have shown 60 to 70% of people have full mystical experiences, we've also shown that about 30% of people have experiences of very significant fear, anxiety, or even terror during these experiences. Now, very often those experiences, these negatively valenced experiences, are short-lived, but not always. And they can be very uncomfortable experiences. As a matter of fact, among the most uncomfortable experiences that people have ever had psychologically in their lives. I think I want to underscore that because it says something important. We have volunteers who are carefully selected, carefully prepared, and they're carefully monitored, and yet we have a 30% rate of these potentially difficult experiences. It's not hard to imagine that administration of these compounds under unsupervised conditions could lead to people to engaging in panic reactions or fearful reactions in which they could put themselves or others in harm's way. There are, like it or not, there are repeated reports of people engaging in catastrophic behaviors, jumping out of windows, jumping off of cliffs, running into traffic. And it looks like a lot of that is due simply to a terror response. And so there's that risk associated with these compounds. And then there's another risk that we try to protect against in screening people, and that is that there is this concern that people who are psychiatrically vulnerable, people who might be disposed towards psychotic process, might just be pushed over the edge with an experience of this sort. There's no hard data to support that, but there are case reports suggesting that that could be a possibility. within the context in which we do research, we need to be ultra cautious. We're in a major medical school. We eliminate anyone with first or second degree relatives with psychotic process. We eliminate people who have borderline personalities or who really appear psychiatrically vulnerable. And so, there are risks associated with using these compounds. And so what I don't want my message to be that there are none. I think there needs to be a boatload of wisdom and context that goes into conditions that support the administration of these compounds.